delirium is characterized by the rapid onset of symptoms and tends to fluctuate within altered level of consciousness with an inability to focus, sustain, or shift attention, and also a change in cognition. It is a physiological consequence of another underlying disease.
Delirium is a common complication in hospitalized older adults. In fact, among elderly patients admitted to ICU, the delirium incidence can reach up to 70 to 80%. Some factors that contribute to the development of delirium include polypharmacy, immobility, pain, their environment. These are some modifiable risk factors, and some non-modifiable risk factors include advanced age and dementia, which is the most prominent risk factor for delirium. As nurses, we can reduce the incidence and severity of delirium by identifying some of those modifiable risk factors that I previously mentioned, and we can implement early regular screenings for delirium and apply the appropriate interventions, and these will be discussed more shortly.
Hi, so I'm Christina. I'm going to be covering our group's discussion on the background of delirium. So delirium has acute onset that impairs one's attention and cognitive function related to several underlying causative factors such as fluid and electrolyte imbalances, poor nutrition, infections, fractures, sleep disturbances, sensory impairments, history of depression, and comorbidities like diabetes, heart failure, and especially those cognitive disorders like dementia and Parkinson's disease. These risk factors are most common in older adult populations aged 65 and older. According to our text, Healthy Adult Aging by Boltz, upon admission to the hospital, 10 to 31% of older adults aged 65 and older have delirium, and 11% to 42% of older adults develop delirium during their hospitalization. Those older adults also have complications during hospitalization. Specifically, it talked about advanced fractures. So with hip fractures, post-surgery, in addition to complications such as hip fractures or cancers, older adult patients with pre-existing cognitive disorders such as dementia end up with increased rates of delirium. 66% of all cases of delirium occur in patients with dementia. Older adults who develop delirium have increased hospital stays, rates of mortality, longer periods requiring ventilation in ICUs, and additional needs that require them to transfer to long-term care facilities, as well as further geriatric syndrome complications. Some of the main geriatric syndrome complications are falls related to dizziness, physical decline in mobility, fragility, pressure ulcers, incontinence, and increase in functional decline. Many patients suffering from the history of depression also have increased incidences of delirium or prolong their postoperative delirium episodes. According to U.S. National Library of Medicine, an article entitled Delirium and Depression, Interrelationship and Overlap in Elderly People, major depression have rates of 45% in the elderly population related to their comorbidities such as Parkinson's disease, cardiovascular diseases, and diabetes. So this ends up complicating delirium, so it increases rates of delirium by approximately 20 to 30%. Patients on multiple medication therapy can enhance incidences of toxicity levels of the medication in their body. Patients with toxicity increases their sympathetic nervous system, such as restlessness, hypervigilance, agitated delirium, impaired judgment, paranoia, and psychosis symptoms, which were like hallucinations or illusions. Discussing outcomes with delirium in the hospital setting. So delirium cases in hospital settings still occur in wide amounts in the geriatric population due to it being poorly understood, poorly diagnosed, and poorly managed. To prevent delirium requires improvements in healthcare professionals' knowledge and understanding of delirium, which includes knowing the risk assessments. To assess a patient, according to the National Institute of Healthcare, patients aged 65 and over should be screened for delirium upon admission to the hospital. Improvements in nursing management can help reduce complications of delirium in the hospital. Monitoring changes in someone's cognitive or physical functions from their baseline and providing supportive care and preventing can help prevent further complications. Monitoring is key to ensuring patient safety and providing interventions from least invasive to most invasive. So least invasive would be more things like those with sensory impairments, just making sure they have their glasses in reach or their hearing aids in, having the rooms with calendars or notes so that they reorient to their environment as well as the dates. And then most invasive would be, if need be, for the safety of the patient as well as the staff, to maybe getting them like antipsychotic meds. Prevention of delirium requires a multidisciplinary team for the assessment and treatment of cognitive impairments or disorientation and physical complaints, such as dehydration or constipation, poor nutrition, metabolic disorders, hypoxia, immobility, infection, pain, and sleep disturbance. So the main
and I will be talking about the nursing assessment for delirium. So according to the textbook bolds, nursing assessment for delirium should always happen on admission and continue throughout the patient's stay. The nurse's first step in assessment is to identify risk factors that puts the patient at higher risk for developing delirium. Risk factors such as old age, being 65 years and old, being in pain, being on multiple medications, if they have any infection on admission, or if they have any electrolyte imbalances. It is important for the nurse to identify these risk factors so the nurse can appropriately intervene and prevent delirium. There's multiple tools that nurses can use to assess delirium, such as the confusion assessment method, delirium rating scale, the memorial delirium assessment, and nursing delirium screening scale. The most commonly used ones are the CAM, which is the confusion assessment, and the nursing delirium screening scale. The CAM identifies 4 features, which is its onset, its inattention of the patient, its disorganized thinking, and if they have any altered level of consciousness. The nursing delirium screening scale, it's based on the confusion rating scale, and it's identifying disorientation, any appropriate behavior, any appropriate communication, or any illusions or hallucinations. They also added a 5th symptom, which is psychomotor retardation. Its rating scale goes from 0, showing no symptoms, and then must score at a 2 or higher to be considered positive. According to the researchgate.net, the CAM sensitivity is 94 to 100%, and its specificity is 89 to 95%, which makes the CAM a reliable test. The breakdown of this assessment is its onset. Is it acute? Did it happen overnight, or is it happening over slowly period of time? Disorientation. Was the patient disorientated at any time during the interview? Did the patient think they were in another place other than the hospital, or was the patient going to a different room other than his assigned? Its level of consciousness. Is he lethargic? Is he stupor? Is he in coma? Or is he alert? Sometimes, however, formal screening is not always possible when the patient is too sick or the patient is too altered to answer any of the questions. So the nurse should substitute the tools mentioned earlier for a quick assessment, such as its orientation to place and time. Do stereo 7s if they can count from 7s, or if they can count from 10 backwards. And if there's any suspicion, it should be handled as delirious and to prevent otherwise.
Hi, I'm Kayla Washkowski, and today we're going to be discussing strategies and interventions for patients experiencing delirium in the hospital setting. First and foremost, you want to promote overall care for the patient and their well-being. You can do this by reintroducing yourself and making sure that they know where they are and contacting case management to ensure that they have adequate living situations once they leave the hospital. This can help with setting goals for your patient and making sure that they know and have comfort in where they're going. We want to treat underlying illnesses such as Parkinson's disease, cardiovascular diseases, diabetes, and dementia. Treating specific symptoms, we want to apply oxygen. And labs, we want to obtain labs to make sure their fluid and electrolyte levels are being met. And we want to make sure that the medications specific to their illness are being taken. This will all help reduce symptoms related to delirium. Also, catheterization highly contributes to the complication of delirium. So we want to make sure that they're on the catheter for as little time as possible, and we want to make sure we maintain a sterile environment during catheterization at all times. Secondly, or third of all, we want to promote a peaceful environment. We want to refrain from using restraints and psychotropic medications because psychotropic medications can cause confusion and further the agitation that comes from being confused when you're in a delirious state. We want to encourage sleep and nutrition. Often the most basic care that's neglected can lead to delirium. This can indicate to further living interventions that need to be assessed related to self-negligence or caregiver negligence. This can be done, we want to try and do this the most from a least invasive to most invasive effect. So we want to make sure that they have food and water and that they're eating that. And if that doesn't work, we will have to go to IV bags and intravenous medication to make sure that they're getting the supplementation and nutrients they need. We want to encourage family involvement. Get the spouse involved, get the daughters and children involved. This will make the patient feel more secure and reduce agitation related to like confusion. It will also allow you to educate the caregiver or someone in addition to the patient so that they can have continuity of care once they get discharged. And have a better chance of adhering to their care plan. We want to make sure we communicate clearly because even though they have other people assisting with their care, they should be the focus of their care. And we want to make sure they're involved as possible. And lastly, we should promote mobility and cognitive stimuli. This increases blood flow to the brain, which helps decrease the state of delirium and assists the patient in maintaining or gaining back their physical strength during their hospital stay. Now back to you, Carolina, for our conclusion.
Okay. So as we have learned, delirium is a serious complication of hospitalization in older adults. This condition is underdiagnosed and underrecognized because, as we have learned, it is poorly understood, therefore it's poorly managed. But as nurses, we can reduce the incidence and severity of delirium by first identifying those risk factors and implementing preventative measures. And these include basic nursing practices such as reorientation, meeting their high nutrition and hydration needs, appropriate sleep, vision and hearing adaptation. And if delirium does develop, early detection is of utmost importance to treat the underlying pathology. So prevention and early detection can be possible with routine risk assessments and regular screenings for delirium. And our recommendation is that this should be a part of comprehensive nursing care for older adults.
It is also important to educate them on the potential for reoccurrence and how they themselves can take these measures at home to prevent this complication from reoccurring.